phosphorus, and magnesium. Okay. So as an introduction, minerals are inorganic elements that come from the earth. Okay, it's classified as major or macro or trace as micro. So there is a classification how to classify which nutrient to be macro and which nutrient to be micro. So minerals are referred to as ions when they carry a charge. So you can have positive ions and negative ions. Might be cation or anions. And it functions in the body. They have many functions in the body, and it's varied across the body. So these are the list of macro minerals and micro minerals, sometimes called as trace minerals. So for macro minerals, we have calcium, phosphorus, magnesium. We also have chlorine, sodium, potassium, and sulfur. So in this lecture, I'll be focusing only on the three most important macro minerals, whereas for the other macro minerals, we'll be covering in another topic, which is water and electrolyte balance. Sulfur you have covered in your protein metabolism. Okay, and then we have a lot of other micro minerals or trace minerals, which is iron, zinc, copper, selenium, chromium, iodine, manganese, and molybdenum. Okay, so this will be covered in the next lecture. So for macro minerals, we can see that in the periodical table, we can see sodium here, magnesium, potassium, and calcium. Okay, these are the positive ion. And then we have phosphorus and chlorine over here. So the first macro minerals that we are going to discuss today is calcium. So how many times have you learned about calcium throughout your studies in UKM? Anyone? Several. That's a safe answer. You have learned in nutrition and health, if I'm not mistaken, in year 1, betul?
Yes.
Betul.
So what do you learn in nutrition and health masa tahun 1 dulu on calcium? Apa yang you belajar?
Dia ada kaitan dengan vitamin D.
Okay, so did you learn about the food sources, the RNA during first year?
Yes, RNI.
Apa lagi yang you belajar? Ada tak belajar fungsi, ada belajar metabolism of calcium?
The basic yang ada dalam RNI.
Okay, the basic one as in the RNI. So today we are going into deeper, I suppose, in terms of the metabolism of calcium. But we will do some recalls on the food sources, the RNI, and so on, briefly. Yeah. So calcium is the most abundant divalent cation in the body. We call it divalent cation because calcium is 2+. Food sources, dairy, seafood with bones, some vegetables, especially the green one, nuts and legumes, and fortified foods. Okay. So calcium is only found in small amounts in multivitamins or multimineral supplements. The major calcium supplement forms are in the form of calcium citrate and calcium carbonate. So if it's in calcium carbonate, it may be contaminated with aluminium or lead if from fossils, oysters, shell, or dolomite. Okay, and bone meal preparation may also contain lead. So these are some of the bahaya of consuming calcium from the supplement. So in terms of the digestion and absorption, so the digestion is present in relatively insoluble salt, And if it's solubilized, it can bind to other compounds. So in terms of the absorption processes, it goes through saturable, carrier-mediated, active, and transcellular transport, and also diffusion process. In terms of this is methods of absorption of calcium. So the main transport of calcium it happens in duodenum and proximal duodenum. So I suppose you already know where is duodenum and proximal duodenum. Kalau tak ingat, you have to open your anatomy book, or you have to Google the image. The transport in duodenum and proximal duodenum is based on saturable and requires energy and regulated by the calcitriol. And in the diffusion process, it's a passive, non-saturable and non-regulated process, and it occurs in small intestine, mostly duodenum and ileum. For calcium transport, it is bound to proteins, example like albumin, prealbumin, and globulin, and it's complex with sulfate, phosphate, citrate, and also bicarbonate. But it is transported as a free ion in the blood, and it is protein bound calcium in equilibrium with ionized calcium. We can find protein-bound calcium and ionized calcium in the blood, so that it's stable. It's not there is no imbalance in the blood. Okay. So in terms of regulation and homeostasis, so this is the important section for our advanced nutrition topic. So the extracellular calcium concentration is regulated by PTH, calcitriol, and calcitonin. So who knows what is PTH? Anyone want to try?
Parathyroid hormone.
Okay, good.
Parathyroid hormone.
Okay, good. So PTH is parathyroid hormone. So kat mana hormon ni? Where can we find ataupun where it is produced in our body? Where is PTH produced in our body? Kat mana?
Parathyroid gland.
Parathyroid gland. So where is it? Di mana agaknya parathyroid gland? Di telinga ke? Di perut ke? Yes, anyone?
Dekat tengkuk.
Dekat mana?
Dekat area lain.
Yeah. Okay, dekat leher, the thyroid area. So there is thyroid, and then you can find parathyroid glands around that thyroid. And then you have calcitriol and calcitonin. These are the regulators of calcium in the extracellular. And in intracellular, calcium concentration is regulated by the calcium and sodium pump, and it exchange moves of calcium in and out of a cell. So this figure shows the calcium digestion, absorption, and transport. So you can find this figure in the textbook. So I think everyone has the Gropper and Smith textbook. Betul tak? Ada soft copy, right? Tak ada?
Ada.
Ada. Okay. So you can refer to that. You can read the textbook to get a bigger picture. So So you can find small numbers here, 1, 2, 3, 4, okay, another 1, 2, 3 here, okay. So these are all the processes that happens in terms of the digestion, absorption, and transport of calcium. So to walk through the process, so you have your small intestine, and dekat area lumen of the small intestine, you have the calcium salts, okay? And then you have the calcium absorption, which is fighting oxalic acid, divalent cations, and unabsorbed fatty acids, okay? So inhibitors, kerja dia jahat, kerja dia adalah untuk inhibit the calcium from being absorbed. So it quickly binds to the calcium and excreted in the feces. Okay. So the other calcium salts dalam kawasan lumen of the small intestine, it meets with the acidic environment in the small intestine, so which is a good calcium. And this calcium salt, when it meets the acidic environment, dia akan jadi dalam bentuk calcium ion, okay, C+, C2+, sorry. So this C2+ crosses the brush border membrane of the enterocyte through a calcium channel, which we call as TRPV6. Okay, so this is the brush border membrane of the enterocytes. So sebenarnya dekat mana enterocyte ni?
Intestine.
Yes, dekat dinding small intestine. So ini kawasan lumen, and this enterocytes is on the walls of small intestine. So this calcium then binds to the, dia dah masuk dah dekat melalui brush border membrane. It binds with cal binding here, and then cal binding carries the calcium across the cytosol of the enterocyte. So dia bergerak. Dia jadi macam sampan. Cal binding is the port to transport calcium ion in the cytosol of the enterocyte. And then calcium binds with ATPase or sodium calcium exchanger pump, and pump calcium across the basolateral membrane. So these are the basolateral membrane for entrance into the blood. Okay, so bila dia dah keluar, dia akan jadi free calcium ion semula di dalam bentuk di dalam blood. Okay, so similarly, calcium also is sometimes absorbed in between the cells. Okay, dia menyelit di celah-celah enterocyte, typically with high calcium ion concentration in the lumen. So kalau banyak sangat calcium ion dalam lumen, dia akan berjaya mencelah di celah enterocyte in between the cells through paracellular diffusion, and then it frees itself as free calcium ion. Okay, so this is basically what you have to understand about the calcium absorption. Okay, so there are interaction between calcium and selected nutrients and substances. You have seen just now some of them are inhibitors of calcium absorption. So these are the nutrient substances enhancing calcium absorption. So earlier your friend had mentioned that vitamin D plays a role in calcium. Okay, so vitamin D actually enhance calcium absorption. Sugar and sugar alcohols also enhance calcium absorption. So do proteins. Okay, so kalau kita tengok our calcium sources are from protein source as well. Contohnya adalah dairy product. They are also protein source. Okay. They also have some sugars like lactose. Dia juga ada vitamin D. So bila kita ambil susu, so the calcium is the absorption of calcium is enhanced because of the food matrix of the milk itself. Kalau kita ambil supplement, we might take only isolated calcium or at least ada calcium dan vitamin D dalam supplement, tapi there is no protein, tak ada sugar, it doesn't help to absorb the calcium. So these are the second column is the nutrient or substances inhibiting calcium absorption. So you have seen just now in the previous figure, we have fiber, phytic acid, oxalic acid, excessive divalent cations like zinc 2+, magnesium 2+, and also unabsorbed fatty acid. So these nutrients, macam kita tengok fiber ni, fiber is good for our health, but it inhibits calcium absorption if it is taken at the same time. Is the calcium excretion. Calcium will be absorbed but will be excreted in our urine. If a diet with too high sodium, too high protein and too high caffeine. So kita tengok di sini kalau kita minum susu dengan kopi, kalsium daripada susu mungkin dihalang untuk in our body, but the caffeine actually helps calcium to be excreted dalam urine kita. Maknanya tidak, dia halang daripada penyerapan kalsium. Similarly, a diet high in sodium and protein also, siapa yang suggest high protein diet for weight reduction and so on. This is very high protein, bukan protein biasa yang kita recommend, and also high sodium. It is also will enhance urinary calcium excretion, which is not good for calcium absorption. And the final column shows us the nutrients whose absorption may be inhibited by excessive calcium. Okay, calcium juga kadang-kadang naughty, dia akan inhibit this nutrient when it is excessive in the lumen. So the first nutrient that might be impacted is phosphorus. Second one is iron. Iron is iron ni penting untuk pencegahan iron deficiency anemia. So those who are consuming mega doses of calcium supplements might have problem with their iron in their blood. And also high calcium intake will inhibit fatty acids. Okay, so kalau kita MUFA which is health, so too much calcium also will inhibit all these three nutrients. So this figure shows the blood calcium regulation by parathyroid and calcitriol hormones. Okay, so figure ni nampak saja complicated, but it's actually there are only 6 steps involved in all these processes. So kita dah tahu tadi in the gastrointestinal tract, calcium ion will go through the calcium channel, will bind with cal binding and then go out of the enterocyte as calcium ion again. Okay, so dia akan masuk dalam kita punya blood circulation. So when the blood has a very low calcium concentration, it sends signals to the parathyroid gland dekat dekat leher yang kawan kamu cakap tadi. So it sends signal to parathyroid gland untuk release parathyroid hormone into the blood. So number one, low calcium in the blood. It sends signals to the parathyroid gland. Of course, it goes through hypothalamus and then only akan sampai dekat parathyroid gland. So bila dah ada signal ni, there will be parathyroid hormone secretion will increase into the blood. So this parathyroid hormone and then binds to the cell receptors. The resorption, okay, bukan reabsorption tapi resorption of breakdown of bone minerals for the release of calcium into the blood. So bone kita membantu release all the calcium, bukan all tapi some of the calcium, a small amount that is stored in the bone with the help of parathyroid hormone. So bila dah berlaku begitu, PTH, parathyroid hormone also acts on the kidneys to synthesize the active form of vitamin D, which is calcitriol. So selain daripada memberi signal kepada bone untuk resorption of calcium from the bone, it also goes to the kidney to help synthesize the active form of vitamin D or calcitriol. So parathyroid hormone also, and together with calcitriol, promote the reabsorption of calcium. So ini berbeza dengan resorption tadi. Reabsorption of calcium from the kidney into the blood. So bila dah parathyroid hormone membantu untuk synthesize active form of vitamin D, calcitriol. So parathyroid hormone bersama-sama dengan calcitriol promote the reabsorption of calcium from the kidney into the blood. So kidney ni adalah a place where we tapis things before it goes into the urine. Okay, so bila berlaku reabsorption of calcium dalam kidney, maksudnya instead of being excreted into the urine, the parathyroid hormone and calcitriol halang of excretion ni dan menyuruh untuk reabsorb balik kalsium daripada kidney kembalikan kepada blood. Okay. Leaves the kidney and travels to the intestine where it promotes calcium absorb across the brush border membrane. So calcitriol ni daripada kidney intestine dan membantu absorption process of the calcium into the blood. Okay, so macam mana dia bantu tu ialah by promoting calcium absorption across the brush border membrane and transport the cell in the cell cytosol and egress into the blood area. So now calcium enters the blood, and after some of them are released from the bone, and some of them are released from the kidney, reabsorbed back into the blood. And of course, some of them are absorbed from the intestinal cell. So blood level of calcium pun meningkat. Okay, so that's how calcium is regulated by PTH and calcitriol. So the two main important hormone is parathyroid hormone, which goes to the bone, which goes to the kidney. Calcitriol, which travels to the gastrointestinal tract and also helps in the kidney itself. Okay. Are there any questions so far before we go? We move forward. Ada apa-apa yang perlu saya ulang? Tak ada ya? Okay. So this table shows the effects of parathyroid hormone, calcitriol, and calcitonin on calcium balance. So dalam serum when there is calcium, parathyroid hormone akan meningkat, calcitriol akan meningkat, and calcitonin akan menurun. So bila semua all this happens, you will get calcium in the serum. Okay. Whereas calcium will be stored in the bone when the parathyroid hormone is low. The calcitriol depends. The flow of calcitriol depends on the parathyroid hormone, and when the calcitonin is high. So kalau parathyroid hormone is high, calcitriol is high, and calcitonin is low, there will be a reabsorption at the renal calcium. Whereas kalau parathyroid hormone tinggi, calcium hormone pun tinggi, and calcitonin tak buat apa-apa, there will be reabsorption of intestinal calcium. Okay, so whenever parathyroid hormone is high and calcitriol is high, the level of calcium in the serum will be high. The renal in the calcium will be reabsorbed, and there will be calcium reabsorption in the intestinal. And when parathyroid hormone is low, there will be storage of bone calcium, and at the same time calcitonin juga akan membantu storage of bone calcium. So this slide shows the calcium functions and mechanisms of action. In terms of bone mineralization, cortical bone versus trabecular bone. So there is a difference between these two bone triol and calcitonin to resorb the bone. Besides that, there are other examples of or other roles of calcium in our body. The first one is blood clotting and muscle contraction, and also it helps in membrane permeability. Okay. In terms of excretion, calcium is excreted in urine and feces. It's also excreted in a lesser amount through our skin melalui sweat. Whereas protein, caffeine, and sodium increases urinary excretion, as we have seen in the previous slide. So the RNI, the latest RNI 2017, recommends 1000 milligram per day for both men and women aged 19 to 50 years old. Okay. So what is the recommendation for older men? Siapa boleh jawab? Means that more than 50 years old men, what is the recommendation of RNI? Siapa boleh teka at least? Hello?
1,500.
1,500?
Teka je doktor.
Teka je. Any other guesses from others?
1,000.
1,000. Okay. Jawapannya 1,002. Jawapannya adalah 1,000. Okay. Because the second sentence I wrote there that only older women and younger groups have higher requirements. Of course, during pregnancy, you will have during pregnancy, especially if you're pregnant at an early age, example macam umur sebelum 19 tahun dah pregnant. So your calcium requirement will follow the adolescent's calcium requirement, which is 1,300. During pregnancy, you still need only 1,000 milligram per day. But then during lactation, again, if you are adolescent and lactating, you should follow the recommendation for adolescent. Whereas during lactation, up to 12 months of lactation, you still need only 1,000 milligram per day of calcium. Tetapi women age more than 50 years old needs 1,000 milligram per day of calcium. Kenapa? Why do you think they need more calcium? Anyone? Ramai-ramai ni perempuan kat dalam kelas. Kena tahu ni.
Sebab when they menopause, diorang tiada hormon estrogen, and estrogen tu yang bantu regulate calcium.
Okay, a good try. So bila dia dah menopause, they are at a higher risk of osteoporosis because they are lacking of estrogen, as your friend said just. So they need more calcium from their diet. Okay. Whereas men needs the same amount of calcium throughout their life from 19 years and above. For adolescents daripada umur 10 tahun ke 18 tahun, you need a little bit more calcium compared to the adults group dalam 1,300 mg per day of calcium. This is for both boys and girls because this is the time where your bone is growing and you need more calcium to mineralize the bone. Untuk kanak-kanak umur 1 year to 3 years old, they only need 700 milligram per day. This is because their body weight is kecil lagi, so they need a smaller amount of calcium. So you can see the RNI for a detailed recommendation of calcium for infants, boys and girls, okay, berbeza-beza. If they are breastfed, if they are formula fed, semua requirementnya berbeza-beza, okay. So deficiency of calcium in terms for especially for infants and children, if they have a deficiency of calcium, they are at develop rickets, okay. And it also happens that bila ada deficiency of calcium, dia juga pada masa sama akan ada co-deficiency of vitamin D. For adults, if there is a deficiency, they are at risk of osteoporosis. And too low calcium blood may lead to tetany. Okay. Dari segi toxicity, the upper level of toxicity 100 milligram per day, amount of calcium yang boleh ditolerate oleh human adalah 2500 milligram per day. So bila berlaku toxicity, you will see signs of idiopathic hypercalciuria. So means that too many calcium will be excreted through the urine, hypercalciuria. And you also have calcium alkali syndrome dalam badan kita. Macam mana we want to assess calcium level in our body? First one will be serum calcium, but then it is so well regulated in our body sebab our body is sangat bijak. Whenever there is a low concentration, dia akan cepat-cepat buat all the process of resorption and reabsorption and so on. We have learned this just now. So serum calcium only indicates a very detailed information of calcium status or calcium intake. So serum calcium is not a biomarker of calcium intake. It cannot be a biomarker of calcium intake or calcium status. So the best is to look at the serum albumin, and this will estimate the protein bound calcium, okay, in our body. So another way of assessing calcium is by looking at the bone densitometry using DEXA, dual energy X-ray absorptiometry. You can also use CT scans, but CT scans are less. So calcium interaction with other nutrients. So ingestion of large amount of calcium with phosphorus containing foods inhibits phosphorus absorption. So terlalu banyak calcium, we have also discussed about inhibit phosphorus absorption. Calcium also decreases iron absorption, but there is this is only for calcium, also diminish absorptions of fatty acids in the intestine. So that's all for calcium. Any questions so far? Tak ada soalan. So I'm going to share with you alamak mana ya? I'm going to share with you a video on calcium and phosphorus regulation to help you understand more about the processes. Let me share the video. Okay, boleh nampak ke YouTube ni ataupun ada benda yang halang dia?
Boleh nampak, doktor.
Okay, good.
Armando Hasurungan, Biology and Medicine videos. Please make sure to subscribe. Join the forum and group for the latest videos. Please visit Facebook Armando Hasurungan. In this video, we're going to look at calcium and phosphate regulation. So the hormones essentially involved in regulating calcium and phosphate levels in the blood. And there are three important hormones involved. These are vitamin D, parathyroid hormone, and calcitonin.
Before that, can you hear the video punya voice?
Yes.
Yes.
Okay. Okay, good.
Endocrinology, calcium and phosphate hormones essentially involved in regulating calcium and phosphate levels in the blood. And there are three important hormones involved. These are vitamin D, parathyroid hormone, and calcitonin. So like all endocrine systems, we should look at what glands and what tissues are involved. So here I'm drawing the brain where we have the hypothalamus and the pituitary gland. But surprisingly enough, we look at these in this video. We will, however, look at this gland here called the thyroid gland, which is situated on our throat. This is a dorsal view of the thyroid gland. So it's the view from the back. And at the back of the thyroid gland, we can find four glands, additional glands, which are different, called the parathyroid glands. And we have four of these on the dorsal side of the thyroid gland. Other important organs and stuff that we will talk about in this video include, because this is where calcium and phosphate can be found, the minerals. And actually most of the calcium is 99% is stored in the bone. And we also will talk about the kidneys, the gut, the GIT, the liver, as well as the skin. So let us first, the hormone that we'll firstly concentrate on is the parathyroid hormone. But before that, we have to see what the significance of calcium and phosphate is in our body. So we have to regulate calcium and phosphate levels because, for one, calcium is important for muscle contraction, nerve conduction, and phosphate is important for other biochemical processes as well as energy. So now let's look at the first hormone, which is parathyroid hormone. So parathyroid hormone is released when we have a decrease in plasma calcium levels. So a decrease in plasma calcium levels will stimulate the parathyroid gland to release a hormone called parathyroid hormone. Parathyroid hormone targets a few things. Firstly, it targets the bone. It stimulates the bone to to break down its minerals so that calcium and phosphate can enter the plasma. Therefore, it increases calcium and phosphate levels in the plasma. The parathyroid is an enzyme in the kidneys called 1-alpha hydroxylase. 1-alpha hydroxylase's main function is to activate vitamin D. So what it does is it converts a chemical to 25-hydroxy vitamin D3, also known as calcidiol, to 1,2,5-dihydroxy vitamin D3, which is calcitriol. So calcitriol is the active form of vitamin D. Calcitriol then targets a few things. Firstly, it stimulates the bone as well somehow, and it to break it down so that we can increase the minerals, calcium and phosphate in. Calcitriol also has a negative feedback on the parathyroid gland, so it inhibits it. Because if we have so much calcitriol, we don't need that much parathyroid hormone anymore. And then calcitriol also targets the GIT. It stimulates the GIT to increase calcium and phosphate absorption. Calcitriol also targets the kidneys itself. So if we zoom into the functional units of the kidneys, these are the nephrons. Here I am drawing one nephron. The nephron is made up of the head, the proximal PCT, loop of Henle, LOA, distal convoluted tubule, DCT, and collecting ducts, CD. So calcitriol actually targets the proximal convoluted tubules here to stimulate the reabsorption of calcium, thus increasing plasma calcium levels. In this diagram, in the nephron, the parathyroid hormone also has an effect, but it has an effect on the distal convoluted tubules. It stimulates in the distal convoluted tubules to reabsorb calcium as well, thereby increasing plasma calcium levels. So now, I hope that all made sense. Now let's go back to calcidiol and calcitriol. Calcitriol being the active form of vitamin D. But where do these things come from? Well, actually, the 25-hydroxy vitamin D3 or calcidiol comes from the liver, but the whole process actually originates in the skin. In the skin, we have a chemical just there, a cholesterol there known as 7-dehydroxycholesterol. And when the sun's UV rays hits this, it actually converts 7-dehydroxycholesterol to vitamin D3, cholecalciferol. And this all occurs in the skin. Cholecalciferol then travels to the liver, where it gets converted by the liver enzymes to 25-hydroxy vitamin D3, or calcidiol. And then this calcidiol is what moves into the kidneys, and in the kidneys, calcidiol, as we know, gets converted by 1-alpha hydroxylase. So I hope that all made sense. So essentially, when we look back at the three important hormones, vitamin D, its main goal is to increase plasma calcium levels. Parathyroid hormone, its main goal is to increase calcium plasma levels as well. Now, whereas calcitonin does the opposite, it will aim to decrease plasma calcium levels. So we can say that if there is, for example, an increase in plasma calcium levels, this will stimulate the thyroid gland, and it will stimulate the thyroid gland to produce calcitonin. Calcitonin essentially has the opposite effect of parathyroid hormone. So calcitonin's goal is to decrease plasma calcium levels when we have an increase of it. But I think calcitonin does not have that big of a role, much of a role in the human body as compared. It does have a role, but not as significant as parathyroid hormone. So I hope you understood the main goal, the main roles of the three important hormones in calcium and phosphate regulation. But it is important to look into a bit more detail at how parathyroid hormone elicits its effects on the bone. Because the bone, as I mentioned earlier, is the main reservoir for calcium, the minerals. So the bone are made up of two main cells that we will talk about. These are osteoblasts, which build bone, and these are osteoclasts, which break down bone. However, this osteoclast is not activated yet. So we call it a pre-osteoclast. And it is the active osteoclast that will resorb bone. So it will break down bone, which will allow calcium and phosphate to be released in the blood. So here I'm drawing a bone again, a simplified diagram. And on the outside we have the hard bone, also known as a compact bone, where we can find collagen as well as minerals. And this is what bone is made up of essentially. And then on the part we have soft bone. But in this case, I just go that. Okay, so now let's go back to the osteoblast. And because osteoblasts have the main role in activating these osteoclasts, even though they have opposite roles. So on osteoblasts, we have a receptor, the parathyroid hormone receptor. So when parathyroid hormone comes along, it will bind onto this receptor and it will have three effects on the osteoblast. Firstly, it will cause osteoblasts to proliferate. Second, it will stimulate the expression of rank ligand on the osteoblast. Thirdly, the parathyroid hormone will cause osteoblasts to stop making osteoprotegerin. Now, osteoprotegerin, also known as OP, normally inhibits basically the activity of rank ligand binding onto another receptor. So basically, parathyroid hormone inhibits this process, so it doesn't want OPG to have an effect. Now, on pre-osteoclast, the pre-osteoclast expresses a receptor called the rank receptor. So essentially what happens is the rank ligand being expressed on osteoblast will bind onto the rank on the pre-osteoclast. And when this occurs, and when it's not inhibited by OPG, the rank ligand rank complex will cause the osteoclast to proliferate and differentiate. There's another chemical which has sort of stimulates this whole process as well, where on the osteoclast we have a receptor CFMS, and the chemical that I'm talking about is macrophage colony stimulating factor, or MCSF. And when MCSF binds onto this receptor, it will stimulate the osteoclast to proliferate and to differentiate. So if either of these things occur, the pre-osteoclast will then become an active osteoclast, and it will become multinucleated. Osteoclasts are actually big things. It's much bigger than osteoblasts. And it is a type of macrophage. That's why macrophage colony stimulating factor. So here we have osteoclasts, which will release some form of acid. And when it releases acid, it will basically eat away on the bone, and this will cause bone resorption. So it will allow the minerals to leave out of the bone. And these minerals that I'm talking about are calcium and phosphate. So it's essentially parathyroid hormone stimulates this whole process, thereby allowing osteoclasts to become activated and to basically release calcium and phosphate from the bone by eating it up. And just to recap, osteoblasts have the opposite effect in that their main goal is to build bone. So they are the ones that release collagen as well as some minerals. So I hope you enjoyed this video on endocrinology, calcium and phosphate regulation. We looked at three main hormones: vitamin D, active form, calcitriol, parathyroid hormone, as well as calcitonin. Thank you for watching.
Okay. How was the video?
It's fine.
Fine. Okay. So I'm giving you the link of the video in UKM Folio so that for those who are interested to watch back, you can watch it through YouTube, through the link. Okay. So if you read the textbook, yeah, the textbooks explained in detail about all those processes explained by the video. So I thought the video will be helpful, especially for those um, who are more comfortable listening and watching to animation instead of reading text. So let's move to phosphorus, our second mineral that we are going to see today. So we have seen in the video that phosphorus and calcium regulation are also related to one another. So phosphorus is the second most abundant mineral in the body after calcium, and it is widely distributed in foods like meat, poultry, fish, eggs, and milk. Cola types are soft drinks. Phosphate containing food additives like inorganic phosphate salts, and it is also found in some food as phytic acid, which is less bioavailable to our body. So in terms of the digestion of the phosphorus, it is hydrolyzed to inorganic phosphate in our body, and the absorption of phosphate undergo two processes. First one is saturable carrier mediated and active transport, and second process is diffusion. And phosphorus absorption is stimulated by calcitriol, as you have seen in the video just now. It is also inhibited by phytic acid, excessive magnesium, aluminium, and calcium. Phosphorus is quickly absorbed from the intestine in several inorganic forms into the blood during their transportation. And the typical range of plasma inorganic phosphate concentration is between 2.5 to 4.5 milligram per deciliter. And when the phosphorus is transported throughout the body, the uptake into the cells are thought to occur passively, where the mechanism is still unclear. Okay, so what we understand now, the uptake into the cell is happens passively, not actively. So this figure shows you the phosphorus transport in the small intestine into the blood. Okay, so again, you are seeing the similar image here. You have small intestine, and this is the lumen area of the small intestine. And then you have your enterocyte at the walls of the small intestine, and here you have your blood. So the first process is organically bound phosphorus absorbed by diffusion through the enterocytes. Okay, and then it can also absorbed actively through the sodium phosphate co-transporter here at the brush border membrane, and then goes into the blood. So there are two modes of transport for organically bound phosphate. These are, first is diffusion, and the second one is active transport. Okay. So phosphorus regulation and homeostasis is influenced by, again, parathyroid hormone, which we found in regulation and homeostasis of calcium, and also fibroblast growth factor 23. And calcitriol and calcitonin also contribute to the regulation and homeostasis of phosphorus, similar to calcium. So there are several functions and mechanisms of actions of phosphorus. The first one, of course, is bone mineralization. It is found in calcium phosphate forms. So you have calcium and phosphate there. Phosphorus concentration in the fluid surrounding the bone is important for the osteoblast and osteoclast function, as you have seen in the video previously. So phosphate is also important in nucleic acid formation, where phosphate is the structural structural roles in nucleic acid formation. So in our DNAs, yeah, we have phosphorus as the bonds between nucleic acids. It also acts as an energy storage and transfer. So remember our ATPs. So you have high energy phosphate bonds in our ATPs. Okay, so these are the three main functions of phosphorus. In terms of mechanisms of action, in intracellular, phosphorus acts as a second messenger of signaling compound, and phosphoproteins and phosphorylated forms of vitamins. So when you learn about vitamins and proteins, you must have heard about phosphorus. And pada cell membranes, you have phospholipids, and it also acts as a acid-base balance as a buffer in extracellular of the cell, and it acts for the oxygen availability. So phosphorus is excreted through urine and feces, similar to calcium. When there is a high dietary intake of phosphorus, the serum levels will increase, and more phosphorus will be excreted through urine. So in terms of recommended nutrient intake for Malaysian, phosphorus R&I for those who age more than 19 years up to elderly is 700 milligram per day for both men and women. Deficiency is rare, but if there is a deficiency, you get premature infants and also refeeding syndrome if there is a phosphorus deficiency. And in terms of toxicity, the upper tolerable level for age 9 to 70 years old is 4 gram per day, means that 4,000 milligram per day. For those who are more than 70 years old, it's 3 gram per day or 3,000 milligram per day. So the recommended intake is only 700 milligram per day or 0.7 gram per day. So how to assess phosphorus in our body? The first one will be serum concentration, and also we can look at urinary excretion. So both serum concentration and urinary excretion has low specificity and sensitivity. And serum concentration can be maintained at an expense of tissues. So it can be stored in tissues. Okay, is there any question so far for phosphorus? Ada soalan untuk phosphorus? I think tak ada. It's quite clear, and it's very much related to your calcium regulation and homeostasis. Okay, let's move to the third and final macro minerals that we are going to learn today, which is magnesium. So the source of magnesium is from nuts, seeds, and whole grains, green leafy vegetables, legumes, lentils, spices, dairy, hard tap water, commonly supplemented as magnesium salts. When a food undergoes food processing, it reduces the magnesium content we refine whole calcium will be lost throughout the magnesium will be lost throughout the magnesium interacts with other nutrients, inhibits phosphorus absorption. So calcium and phosphorus adalah satu geng yang sama, whereas magnesium antagonist to this phosphorus. So magnesium actually inhibits phosphorus absorption, and it influences magnesium is an antagonist. Kenapa? Apa ciri-ciri dia yang menyebabkan dia menjadi antagonist to phosphorus and also calcium and potassium? Kenapa agaknya? I think I've shown in the previous slides the reason. Say that was the reason. Siapa boleh bantu highlightkan? Anyone nak cuba? Tak apa, salah.
Sebab they compete for the binding. There's nutrient interaction.
Ya, sebab apa dia compete tu? Why they compete between each other? If we look back, you can see magnesium is an inhibitor to phosphorus transport. Tengok lagi. Yeah, here. Kat sini. Kenapa dia menjadi inhibitor to calcium and to phosphorus? Because of what? Apa ciri magnesium ni? Ada siapa-siapa yang nampak dan nak share? Tak ada. Because it is a divalent cations. Dekat sini ada tulis divalent cations. So magnesium is so they compete between each other to be absorbed into the intestine. Okay, disebabkan dia adalah divalent cation, sentiasa berebut antara satu sama lain. Okay. So excretion of magnesium is plasma concentration, because when the plasma concentration is high, it will be excreted through the feces, mostly yang tak berjaya diabsorb, unabsorbed magnesium are excreted to the feces, and also through the skin melalui sweat. So there are two systems for absorption of magnesium. First one is saturable, carrier mediated, and active transport. This is very low magnesium intake. The second one is diffusion through passive concentration dependent route. Terutamanya apabila there is a high intake of magnesium. So around 30 to 60% of dietary magnesium are typically absorbed. So this slide shows the nutrients and substances affecting intestinal magnesium column shows vitamin D, fruit and carbohydrate, especially fructose and oligosaccharides. Substances inhibiting the absorption, fiber, and also unabsorbed fatty acids. Whereas has a phosphorus and also potassium. Okay, this slide shows the figure for magnesium absorption and transfer. We can see that again, this is small intestine and these are the lumen area. This is the wall of the small intestine, enterocyte, where enterocytes are, and you have blood at this area. So magnesium 2 plus in our blood crosses through the brush border membrane of the enterocyte through a magnesium channel called TRPM6. Okay, TRPM6 is a magnesium channel at the brush border membrane. So magnesium 2 plus travels through the enterocyte melalui brush border membrane, melalui channel, magnesium channel. So magnesium is also absorbed in between cells, and these absorptions are normally influenced by electron chemical gradient and solvent drag. So this is paracellular diffusion. So in between enterocytes, dia boleh mencelah-celah. Magnesium 2 plus is also pumped out of the enterocyte across the basolateral membrane. So sebelah sini adalah basolateral membrane by a sodium dependent ATPase. So these are the sodium dependent ATPase. So dia boleh keluar daripada enterocyte through the basolateral membrane into the blood through a sodium dependent ATPase. And you have a free magnesium and also a protein bound magnesium in the blood. So kalau protein bound kita dah tahu adalah melalui albumin or globulins. You can also have non-protein complexes magnesium dalam blood kita, especially dalam magnesium citrate, magnesium phosphate or magnesium sulfate. Okay. So we know that there are inhibitors of magnesium ion in small intestine. So the inhibitors are fatty acid, fibers, and unabsorbed fatty acids. So they all bound with the magnesium, cepat-cepat bercantum dengan magnesium, and excreted through the feces. So magnesium are transported as free magnesium ion, around 50 to 55%. So almost half of the magnesium is transported as free magnesium ion. 20 to 30% are bound to protein, example like albumin or globulin, whereas 5 to 15% are complex with the negatively charged anions like sulfate, phosphorus, okay, yang tadi saya sebut tadi, and it's transported with that form. So the kidney controls the magnesium losses in response to plasma concentration, and the bones provide as a reservoir of magnesium. So when the plasma concentration is low, the bone will akan excrete the magnesium stored dalam reservoir mereka. When the plasma concentration is high, it is stored at the bone. So this plasma concentration can be maintained at the expense of the bones itself. There are several hormones influence magnesium balance, especially the main one will be the parathyroid hormone. So the function function and mechanisms of action for magnesium. All those three minerals that we have learned today involved with bone mineralization. So it happens in several forms and on the bone surface and also as a part of the crystal lattice of the bone. Okay, and the enzymatic reaction that happens is magnesium is required for more than 300 enzyme reactions as structural cofactor or allosteric activator dalam badan kita. So magnesium is important for enzymatic reactions in our body. So magnesium ni agak penting dalam kita punya badan. So magnesium also has other roles like for blood clotting, hormone receptor binding and activation of second messenger signaling, ion channel regulation, and also antagonism of intracellular calcium. And it also involved in insulin production, release, and action or signaling. So magnesium deficiency is relatively common among hospitalized individuals, and it may also be underestimated in the general population because plasma concentration always appear normal at expense of tissue concentration. So bila plasma rendah saja, tissue semua akan keluarkan magnesium to the plasma. Bone also will contribute to the plasma. So kita tak nampak. Okay. Hypomagnesemia has some metabolic effects. So hypomagnesemia means bila dalam blood kita magnesium adalah rendah, apa yang akan berlaku adalah there will be a decreased parathyroid hormone, calcium, potassium, and calcitriol concentration as well. So apa yang akan berlaku semasa magnesium deficiency adalah muscular and cardiovascular symptoms seperti cramp dan sebagainya. So factors that contribute to deficiencies of magnesium is inadequate intake from the diet, excess alcohol use, if you have malabsorptive disorders, okay, if you are consuming medications, and also if you have uncontrolled diabetes and metabolic syndrome. So all these will contribute to the deficiency of magnesium. Heart disease also develops more quickly if magnesium deficiency exists. In terms of toxicity of magnesium, excessive food intake not shown to cause toxicity because the kidney are so great that they can excrete magnesium rapidly. Okay, but then you have an upper limit of 3,500 milligram per day from non-food sources, example daripada supplement dan sebagainya. Excessive intake of magnesium salts may lead to diarrhea and also dehydration, and effects are more likely in individuals with impaired renal function sebab it depend the regulation is at the kidney. So kalau ada masalah pada renal function, you akan ada masalah yang besar pada toxicity of magnesium. So if the kidney fail to excrete